Welcome to the Creative Commons RX podcast. Before diving into this episode, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome to the Deep Dive, where we sift through complex, critical source material to give you the essential knowledge fast.
Today we're tackling a really serious one, a true clinical emergency.
We're looking at Neuroleptic Malignant Syndrome, or NMS.
And it is the definition of a scary acronym. It's a rare but potentially catastrophic drug-induced reaction.
First documented back in the 60s, I think.
Yeah, 1960. And the thing is, if we don't spot it and treat it immediately, the mortality rate, it can still be unacceptably high. The sources we're using today, really detailed clinical toxicology notes, are crucial for this.
Okay, so let's unpack this. For anyone listening, if you're, prepping for rounds or just need to get your head around this syndrome, there's one core concept you have to internalize. What is fundamentally driving NMS?
It all comes down to a central, profound dopamine deficit in the brain.
A lack of dopamine.
A huge lack. NMS is all about dopaminergic hypoactivity in the central nervous system. Too many of those crucial D2 dopamine receptors get blocked, or the supply just gets cut off.
And that lack of dopamine is the engine that drives every single major symptom we see.
Exactly. Once you lock in on that central dopamine deficit, the whole thing sort of snaps into focus.
Right. And that key idea unlocks the three main areas we need to cover today. First, the medications that can cause this, which is a surprisingly broad list.
Yeah, it's not just the classic antipsychotics anymore.
Second, the famous 4 symptoms, the tetrad, that clinicians use for a rapid diagnosis.
And finally, third, the management steps, which includes a very specific, and I mean crucial, rule about how we stop the treatment.
Okay, let's start right there with that core theory, central dopaminergic hypoactivity.
Right. So NMS happens when medications block those D2 dopamine receptors.
Or deplete dopamine stores.
Exactly. Or even when you suddenly stop a drug that's been boosting dopamine. And this isn't just, a guess. It's a clinically supported mechanism.
The evidence is solid.
Oh, it's overwhelming. I mean, look at the drugs. Every single antipsychotic implicated in NMS binds to and antagonizes those D2 receptors.
And the older ones are the worst offenders.
By far. Here's a number that should really stick with you. The older first-generation agents, especially high-potency drugs like haloperidol, they carry the highest risk. It's associated with nearly half of all reported cases. It is just pure, potent D2 blockade.
That's a huge percentage. But what often surprises people, and I think this is where the name neuroleptic is a bit misleading now, is that it's not limited to psychiatric drugs.
No. And this is a fundamental lesson in pharmacology, really. If a drug blocks dopamine receptors in your gut to stop you from vomiting, well, it's blocking them in your brain, too.
So we have to watch out for common anti-nausea meds.
We do. Things like metoclopramide, droperidol, and prochlorperazine. These are everyday medications, but because they are also D2 receptor antagonists, they are fully capable of triggering NMS.
So it's the mechanism, not the drug's intended purpose.
Precisely.
But there's another trigger, which you mentioned, this withdrawal paradox.
Yes.
You can trigger a syndrome that looks identical to NMS, not by giving a drug, but by taking one away too fast.
Exactly. You see this in patients with Parkinson's disease. If they abruptly stop taking their dopamine agonists, drugs that boost dopamine activity like levodopa, their system just crashes.
So it's the same net result.
It's the exact same result, a sudden, severe dopamine deficiency. Whether you block the receptor or you take away the key that stimulates it, the system just starves.
Now, if we dig a bit deeper into the pathophysiology, the sources explain why NMS has this slightly delayed onset. It's not instant.
Right. That's where you get into receptor supersensitivity. If you've been on these D2 blockers for a while, the receptors that are left, They upregulate, they get hyperresponse
So a sudden dose change hits them harder.
massively. If a clinician then rapidly escalates the dose, which is a major risk factor, it causes the sudden marked crash in effective dopamine signaling.
And the rigidity is so severe that it probably involves more than just dopamine.
That's right. The sources point to glutamatergic disinhibition, which is why we sometimes use benzodiazepines in treatment. They're GABA agonists, and they help inhibit those runaway glutamatergic pathways.
It's a whole cascade. So what are the key risk factors clinicians should be screening for?
Well, the list is pretty clear, and thankfully, many are preventable. Rapid initiation or fast dose titration, that's a huge red flag.
Which reflects that move away from rapid tranquilization, right?
Exactly. We also know that using high-potency agents, and this is really important, depot, or long-acting injectable preparations increases the risk significantly.
Why are those depot injections so much riskier?
It's the commitment. Once that depot is in, that drug is in the patient's system for weeks. You can't just stop it. Dehydration, severe agitation, and for you, the learner, remember this number, patients with prior history of NMS have a recurrence risk of up to 30%.
30. That's a risk you just can't ignore.
Okay, so understanding the chemistry is one thing, but recognizing this in the moment is another. That relies on the classic presentation, the tetrad.
This is the checklist you need to run down instantly. The first sign is a change in mental status, altered consciousness.
And this isn't just, a little drowsiness. No, not at all. It ranges from inattentiveness all the way to stupor or even coma. That's linked to the mesocortical and mesolimbic pathways.
Then the second, and maybe the most striking symptom, is the muscular rigidity.
Oh, absolutely. The notes describe this as Parkinsonian, or very specifically, lead pipe rigidity.
Lead pipe?
It's just this constant, severe resistance to movement. And it's happening because of D2 blockade in the nigrostriatum, that deep brain area controlling movement.
And a key point for differentiation, this rigidity won't respond to the usual anticholinergic treatments.
It won't. That's a huge clue.
The third piece of the tetrad is the fever, hyperthermia.
And this is a physical crisis.
Yeah.
Temperatures usually start above 38 Celsius, but they often soar past 40.
And this fever is different.
It is. It's typically not associated with chills, and it is stubbornly unresponsive to your typical antipyretics like Tylenol or ibuprofen.
Why not?
Because the heat is being generated centrally in the hypothalamus, but also from the massive amount of heat produced by those continuously contracting lead pipe muscles.
And that kind of internal heat generation, that's heading toward organ failure.
Fast.
Before we get to the lab markers for that, what's the fourth symptom?
That's autonomic dysfunction. Essentially, your sympathetic nervous system has gone completely haywire. A racing heart, tachycardia, rapid breathing, tachypnea, blood pressure that's all over the place, and just profuse sweating. The body's regulatory systems are completely unstable.
How quickly does this all start after a drug change?
Typically develops within the first 1 to 2 weeks with a median onset of about 4 days. And it progresses fast. Peaks within 2 to 3 days. You don't have time to wait and see.
And you mentioned the depot preparations earlier. That really determines how long this crisis lasts.
It's a vital clinical distinction. For oral meds, recovery is usually around 7 to 11 days. But if the patient got a depot injection,
The drug just stays in the system.
much longer. The duration of the syndrome nearly doubles. We're talking a mean duration of 26 days versus 13 for oral agents. That's weeks of ICU care instead of days.
That makes the diagnosis so urgent, but there's no single blood test for it.
No, diagnosis is purely clinical. History, suspicion, the tetrad. There is no definitive lab test.
Yeah.
But the labs are essential for assessing the damage.
And the most important one is?
Creatine kinase, CK. It's the most frequent abnormality. We're talking levels often exceeding 1,000, sometimes way, way higher.
And that reflects?
Myonecrosis, severe muscle death. That leads to rhabdomyolysis and a high immediate risk of the kidneys failing. That CK is your warning sign of pending organ damage.
Right. And NMS has this great imitator, serotonin syndrome. They share a lot of symptoms.
Yeah.
What's the life-saving difference on the physical exam?
This is the make-or-break moment in the ER. Serotonin syndrome develops fast, within hours, and it's defined by neuromuscular excitation.
So you're looking for?
Hyperreflexia clonus, that rhythmic shaking myoclonus, shivering. It's an excited state.
Whereas NMS?
NMS develops slowly over days, and its signature is that rigid lead pipe tone and critically normal or even diminished tendon reflexes.
So the state of the reflexes is the key.
It's the key differentiator.
Okay, so once NMS is recognized, the speed of intervention is everything. Let's talk management. What is the absolute first step?
The non-negotiable first step is immediate cessation of all implicated antipsychotics or dopamine antagonists. You have to stop the cause. Now,
And the reverse is true for withdrawal-induced cases.
of course, if it's from stopping a Parkinson's drug, you have to promptly restart those dopamine agonists.
Beyond stopping the drug, what level of care is required?
This is an automatic ICU admission. Aggressive supportive care is the cornerstone. You start aggressive physical cooling immediately, ice packs, cooling blankets. Tylenol just won't work on this.
And with those sky-high CK levels and the kidney risk, what's the fluid strategy?
Rapid to V rehydration. You need to flood the system to maintain a normal fluid balance and help flush out all that myoglobin to prevent the kidneys from shutting down.
Cam the airway.
You have to protect the airway. Severe rigidity can compromise breathing, so prophylactic intubation may be necessary.
Let's move to the specific drugs, the ones that treat the underlying cause first.
Right, the dopamine agonists. We're talking about agents like bromocriptine. It's a direct D2 agonist, so it effectively replaces the missing dopamine.
And the data shows it's pretty effective.
Very. Retrospective data show bromocriptine alone was effective in reversing symptoms in nearly 90% of cases. Another option is amantadine.
Okay, and what about the drug that targets the physical symptoms, the rigidity and fever?
That would be dantrolene. It's a powerful, direct skeletal muscle relaxant. It works right inside the muscle cell, stopping the calcium release that causes the contraction.
And by stopping the contraction.
It rapidly reduces the rigidity and the dangerous heat being generated by the muscles.
So if dantrolene is so good at fixing the fever and rigidity, why can't we just use it by itself?
Because it's a symptom fixer, not a root cause fix. The sources are crystal clear on this. Dantrolene does not treat the underlying neurotransmitter problem.
You still have a brain starved of dopamine.
Exactly. So it's essential for reducing the life-threatening CK levels and heat, but it should be used with a dopamine agonist to fix the brain chemistry.
And there's a huge safety warning with dantrolene.
Yes, this is vital. There is a strong contraindication against combining it with certain calcium channel blockers, like verapamil.
Why is that?
That combination carries a really significant risk of severe, life-threatening cardiovascular collapse. It's a known high-risk interaction.
Okay, and finally, what about for milder cases?
That's where benzodiazepines come in, drugs like lorazepam. They're great for managing agitation and providing some muscle relaxation, especially in mild to moderate NMS.
So the patient is getting better. Now we get to what you said is a common mistake. Stopping the meds too soon. The tapering rule.
This is maybe the most critical management detail to remember. If you abruptly stop the bromocriptine or the dantrolene,
Acid syndrome can come roaring back.
it can. You risk recrudescence,
Yeah.
a relapse. To prevent that, these agents must be tapered gradually over 3 to 10 days after symptoms have completely resolved. It's a slow, careful withdrawal.
And for the absolute worst case scenario, extreme rigidity and fever.
Then you have to go to the last resort, neuromuscular paralysis.
A paralyzing agent.
Yes, something like pancuronium. It stops all muscle activity, which stops the heat and CK release. But of course, that instantly requires mechanical ventilation. It is the very last resort.
Moving to prognosis, the good news is that we've gotten a lot better at this. Mortality rates have dropped significantly.
They have, from historic rates of nearly 30% down to somewhere between 0 and about 12% now. That's a huge clinical victory.
It is, but it's still so serious. The sources mention the single strongest predictor of mortality.
Right. It's acute respiratory insufficiency, often from the severe rigidity of the respiratory muscles or from aspiration pneumonia.
And patients who survive, they face this lifelong risk of it happening again.
Up to 30%, so you can't just put them back on the same medication.
No. If they absolutely need an antipsychotic again, there are strict rules.
Very strict. First, you delay. You wait at least 2 weeks, maybe longer, until every single residual symptom is gone, including the lab abnormalities.
And you don't go back to the high-potency drugs.
No, you choose a low-potency or an atypical agent. Clozapine is often cited as a lower-risk choice.
And you start low and go slow.
The lowest possible dose, and you titrate up very, very gradually. And the sources also stress. Avoid using it with lithium, which has been implicated in relapse.
Okay, so to summarize the key takeaways from this deep dive,
Yeah.
NMS equals severe dopamine hypoactivity in the brain.
Diagnosis is clinical, based on that 4-part tetrate altered consciousness, lead pipe rigidity, fever, and autonomic instability,
Outside.
plus those elevated CK levels.
And management is immediate drug cessation, aggressive ICU care, and the targeted use of dopamine agonists and dantrolene.
Both of which need that careful, gradual taper. That's the clinical reality.
Okay, so here's the thought to leave everyone with. If the most critical therapy stopping the drug relies entirely on a clinical diagnosis, how do clinicians balance the pressure to meet rigid diagnostic criteria with the need to act fast, maybe before the full syndrome has even appeared?
That's the question, isn't it? Do you use flexible criteria and initiate life-saving treatment when you see the mental status changes in rigidity even before the really high dangerous fever kicks in?
It's the ultimate test of clinical judgment. Waiting for perfect clarity could be fatal. A fascinating and incredibly high-stakes balancing act.
Indeed.
Thank you for joining the deep dive. We'll see you next time.
This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this podcast is at the user's risk. The content on this podcast is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the audio content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.